Good afternoon, and to those joining us from the United Kingdom, a very special welcome and good evening. I'm Jennifer Rabb, and I have the enormous privilege of serving as the president of Hunter College. It is an honor to welcome you to today's program on the findings of the Lancet Commission on Public Policy and Health during and leading up to the presidency of Donald J. Trump. And what better host could we have than the Roosevelt House Public Policy Institute, an engine of civic discourse on the most pressing policy matters facing our city, state, country, and indeed the world. From the beginning of the pandemic, Roosevelt House has hosted series of online events convening extraordinary scholars and experts from the Hunter faculty and beyond to share their latest research and insights on topics ranging from our nation's racial reckoning to its ongoing public health crisis. In fact, this event takes us full circle back to our very first virtual presentation on the pandemic, when our distinguished professors of public health, Drs. David Himmelstein and Steffi Woolhandler, provided the Hunter community and public with critical perspective on the impact of the COVID-19 outbreak on our medical system. Steffi and David, it is a pleasure to welcome you back to the virtual Roosevelt House stage, and thank you for helping to conceive and guide today's program. In keeping with the Hunter tradition of collaboration with some of the world's leading experts and academic and scholarly institutions, we're especially delighted that you have brought with you guests and colleagues of such renown, including the Congressman from Silicon Valley in California, the Honorable Roel Khanna. Congressman, it is an honor to welcome you to Roosevelt House, and we truly hope one day to welcome you in person. We also welcome former New York City Health Commissioner, friend and partner, Dr. Mary Bassett. Commissioner Bassett, the last time we had the pleasure of welcoming you to Roosevelt House, it was for a memorable discussion of Steffi and David's previous collaboration with the United Kingdom's leading medical journal, The Lancet. Exploring the special issue that they co-edited, the Roosevelt House audience was treated to an evening of important and powerful discoveries on equity in the American healthcare system and the promise to launch and report back on the studies they announced that day. With today's program, we are so very pleased to continue our vital relationship with The Lancet, helping Hunter to stay at the forefront of studying and correcting disparities in health and healthcare. Thank you to the entire Lancet team, and especially its editor-in-chief, Richard Horton. Richard, it's a pleasure to have you with us today. At Hunter and at Roosevelt House, we feel a profound and long-standing connection to the research and policy making that supports and strengthens public health. Today, while faculty, students, and alumni from Hunter's outstanding nursing school continue to battle COVID-19 on the front lines, Hunter faculty from a broad range of disciplines are helping to advance critical research to support public health policy. Professors Woolhandler and Himmelstein are leaders among them. Their tireless work, both as medical doctors and as scholars, has been a powerful inspiration to Hunter's students and has earned them the recognition and admiration nationally and around the world that they deserve. Steffi and David truly exemplify the historic Hunter motto, which has guided generations of students and teachers at Hunter since our founding 150 years ago. Mihi cura futuri, the care of the future is mine. With that, it is my pleasure to hand the program over to the editor-in-chief of The Lancet, Richard Horton. Richard, thank you for bringing this program to Hunter College and for being our partner.
Thank you very much to President Raab. Thank you to Roosevelt House and Hunter College for hosting this launch. Well, welcome everybody. Thank you to our fantastic co-chairs, Steffi Woolhandler, David Himmelstein, and a really incredible team of commissioners, two of whom you'll hear from later today, as President Raab said, Mary Bassett and Kevin Grumbach. And I'd like to thank my colleagues at The Lancet too, Rebecca Cooney, Rebecca Barksby, and Johanna Harvey in particular, who've been working on this project. And also I'd like to thank two particular sponsors for their financial support, the Doris Duke Charitable Foundation and the Open Society Foundations. Now we're launching this commission on the final day of impeachment arguments that are taking place against former President Donald Trump. This is a truly historic moment, a reckoning, if I may say, for a superpower. I am speaking from London in the United Kingdom, a country whose response to the COVID-19 pandemic has been, to put it politely, suboptimal. So I speak with considerable modesty. But as this Commission on Public Policy and Health in the Trump era shows, the president's, and I quote from the Commission, the president's folly of contempt for science, facts, and equity has been truly devastating for the nation, perhaps permanently resetting the geopolitical and ideological balance between nations. 227,000 cases of COVID-19, 464,000 deaths, heading towards 500,000 deaths by mid-March. It's a terrifying legacy for a new administration to confront. But this commission doesn't only look back at the past 4 years, it also looks forward, very importantly, to the priorities for the Biden administration to consider and to address. I would only add this comment as a non-American. A strong and secure America, an America whose values include commitments to international cooperation and multilateral decision-making, is crucial to a stable world order. This commission offers a vision for restating and for remaking those values and those commitments. And the Lancet very much looks forward to working towards those goals in the coming months and years with Steffi, David, and the commissioners. Now I'm going to hand over now to our speakers. We're going to begin. I'm going to introduce them all first, and then we will roll. Steffi Woolhandler, as you know, is a faculty associate at Roosevelt House, distinguished professor of public health at Hunter College and at Harvard University in Boston. Kevin Grumbach is professor of family community medicine at the University of California in San Francisco. Mary Bassett, of course, is a distinguished former commissioner of the New York City Department of Health and Mental Hygiene and is currently director of the Francois Xavier Bagnoud Center for Health and Human Rights at Harvard University. And David Himmelstein, as you know, is also a faculty associate at Roosevelt House and a distinguished professor of public health at Hunter College, New York, and also at Harvard University. So let me hand over straight away to Steffi, who's going to tell you about the commission in more detail. Steffi, a big thanks to you.
Well, as stated, I'm Steffi Woolhandler. I'm one of the co-chairs of this commission. And the commission is about 53 pages, and lucky for you, I'm not going to tell you everything about it today. But what we are going to talk about is 4 years of Trump's health-harming policies, 40 years of policy failures that have undermined the conditions needed for a healthy population, and then 400 years of genocide and white supremacy in the United States that breed health inequities that have poisoned the politics in our country. And when we talk about 4 years of failed policies, we tend to look at what's happened in terms of life expectancy in the United States that has completely stagnated. But that's been going on since about 2010, with several years in there where longevity in the United States fell even before the COVID pandemic. But when we go back a little bit further, we see that life expectancy in the US began to lag behind that of other developed nations, the other nations in the so-called G7, beginning in about 1980, when we were middle of the pack in terms of longevity. But by 2019, life expectancy was 3.4 years shorter than the G7 average. And of course, shorter even still among our Black and Native American populations. Notably, the Native American population has a treaty with the US government that is supposed to provide medical care to people living on or near reservations. And yet Congress has year upon year underfunded the Indian Health Service by a factor of 2 or 3, relative to national health spending. Trump, of course, encouraged a lot of racist, white supremacist folks, calling them very fine people after they murdered someone in Charlottesville, Virginia. And Trump's signature legislative achievement was a $1.9 trillion tax cut, 85% of which went to the wealthiest Americans. And this created a budget hole that justified tremendous cutbacks in social programs needed to support health. Trump opposed environmental regulation, rolled back more than 80 of them, and we actually saw 22,000 more occupational and environmental deaths in 2019 than when Trump came into office after decades of progress in environmental protection. The number of uninsured people had fallen in the United States to about 25 million through the Obamacare legislation, still a problem, 25 million. But Trump undermined the Affordable Care Act in ways large and small, adding about 2.3 million people to the ranks of the uninsured, even before the economic distress of the COVID pandemic. And of course, the problems of being uninsured are much greater for America's poor and our racial minorities than for our white population. But it's taking a step back, this has led to a much larger amount of medical care when measured by dollars spent, a much larger amount of US medical care being delivered to every white person in the United States than to the average Black, Hispanic, or other person of color. This is a form of structural racism that's embedded in our healthcare finance system that values the lives of minority people lower. Trump has been very friendly to the private health insurance industry, whose overhead and profits on a per enrollee basis have been soaring under his administration, and the average employer group plans, $1,104 per enrollee per year, taken off the top of the premiums for overhead and profit. And in the Medicare Advantage program, a privatized form of the public Medicare plan, $2,400 per enrollee per year, taken off the top as overhead and profit this past year. We tend to talk about a private insurance industry in the US. That's really a misnomer. The private health insurance industry gets the majority of its funding from the taxpayers in the form of managed Medicaid payments, Medicare Advantage payments, and the premium costs of government health worker benefits, which are paid for by the taxpayers. So really only about a third of even the private health insurance industry is publicly funded. And this has led to tremendous bureaucratization of the healthcare system to run it as a for-profit business, with the number of managers growing at many times the rate of the number of physicians in the healthcare system. Overall administrative costs in the United States are about $4,000 per capita, almost 3 times what they would be in a simple single-payer Medicare for All program, which the Commission recommends. We could cover everyone and have universal coverage under a single-payer program for about $600 billion less than trying to achieve universal coverage through a multi-payer reform, largely due to those administrative cost savings. So what about the pandemic? Well, even prior to COVID-19, the Trump administration had weakened the ability of the American people and American government to respond to pandemics. In a 2017 hiring freeze at CDC, he left 700 vacant positions. He blocked the release of OSHA's airborne pathogen standard, the occupational standard to prevent airborne illness, in the first couple of months of his presidency. The Obama administration had been working on it for years. He abolished the cabinet net level global health security team. He demoralized our scientific workforce with 1,600 government scientists leaving positions, and Trump left half of key science policy positions vacant. And then when 2020 came, he opposed global cooperation, he quit WHO, he mocked and blocked masking and other simple public health measures that would have saved tens of thousands of lives. Consequently, the US COVID-19 death rate, relative to that of the other G7 nations, who did not do that well, but even relative to the average of the other G7 nations, our death rate was 65.5% higher, leading to 160,000 excess deaths in 2020. And of course, Trump has used militarized policing with mass incarceration and immigrant detention, which is inhumane and unhealthy, particularly in the pandemic. By intimidating minority communities, he has driven up bad outcomes in minority communities, in this case, the rate of preterm birth among Latinx women, which rose immediately after Trump's election. And now I'll hand this over to Professor Kevin Grumbach.
So as Steffi has described, Donald Trump spent 4 years committing malpractice on the health of Americans. But the patient was sick long before Trump took office and COVID-19 arrived. And the disturbing truth is that many of Trump's policies did not represent a radical break with the past. Rather, they accelerated a 40-year-long trend of lagging life expectancy. I'm going to talk about the 4 decades of policy failure that contributed to the nation's ailing health. Steffi earlier showed this slide documenting the widening gap in life expectancy in the United States relative to the other G7 nations. In our commission report, we use the concept of missing Americans to quantify this excess mortality. If life expectancy in the US had been the same as the average life expectancy in other wealthy nations, how many fewer deaths would have occurred in the United States? This slide, based on the research of Commissioner David Bohr and his colleagues, shows a steady increase in the number of missing Americans per year. In 1980, the number of excess deaths in the United States relative to the other G7 nations was 0. The number started growing in the early 1980s, and by 2018, 461,000 Americans went missing. So to put this in perspective, the 461,000 excess deaths in 2018 is more than the number of lives lost in the United States due to COVID-19 in 2020. It is a big and tragic number. The graph also lists presidential administrations along the bottom of the figure. The first administration here is that of Ronald Reagan. Now, it's not a coincidence that the divergence of life expectancy in the United States from the other G7 nations began during the Reagan administration. Reagan's victory signaled the end of the New Deal and civil rights order and a decisive turn to conservative policies that eroded social programs enacted under Democratic administrations that had improved health and reduced racial disparities. So even as productivity grew in the 1980s and 90s, the rewards flowed to firms' owners, wages flattened, jobs became increasingly precarious, and life expectancy began to lag. Many Trump policies, such as windfall tax cuts for the rich, increasing privatization of Medicare, and rollbacks of environmental protections, were rooted in Reagan conservatism. Now, illustrative of the consequences of the policy shift during this 40-year epoch is a tremendous growth in income inequality. In 1980, if you go back here, the bottom half of households in the United States in terms of income accounted for 20% of all income earned that year. And the richest 1% of households had a little more than 10% share of income. Now this trend shifted dramatically after 1980, with a growing share of the nation's income concentrated among the richest 1% of households and a declining share of income among half of the people in the lower income group. Let me show you another trend that had an inflection point in 1980. Until about 1980, healthcare spending as a percent of gross domestic product in the United States was comparable to that of other nations such as Canada and Germany. You see though, in 1980, things started to diverge. And by 2018, expenditures in the United States were more than 60% greater in these comparable nations. So how do we reconcile these two facts? The highest healthcare spending in the world by far, and life expectancy 3.4 years less than that in comparable nations. So one answer is the failure to invest in the conditions that make for a healthy population. The United States enacts tax cuts for the wealthy and lets giant corporations like Amazon pay nothing in taxes. Other nations raise more in progressive taxes and spend that money on the public good, free universal education, paid parental leave, housing subsidies, all things that contribute to healthy lives. The United States is also unrivaled in its profligate waste in health spending. Steffi alluded to the hundreds of billions of dollars every year siphoned off into health industry profits and administrative expenses. Steffi showed this slide, which is the growth of managers compared to physicians. You know, you tell me in this slide, where is value-based care, something we talk a lot about in the United States, in this type of ratio of managers to actual caregivers? And where else but in the United States would even end-of-life care, something really a sacred duty of health professionals and families, end-of-life care, how could that be turned into a profit-making enterprise? 2/3 of all hospices in this country are investor-owned. Some have said that the United States has less of a healthcare system than a wealth care system. It works well for the economic interests of the healthcare industry. And as this slide shows, it is now preferentially spending more and more money on the highest income group among our population, despite them having less healthcare needs than lower income groups. And you can see this rise of concentration of spending on the highest income groups in the last decade. So far did the political compass move to the right under Reagan that even when Democrats won back the White House in the Clinton and Obama years, policies still tilted in a pro-market, pro-corporate direction. President Obama's signature legislative accomplishment, the Affordable Care Act, was attacked by Republicans as a socialist takeover of medicine. This Times Magazine cover shows Obama in the image of FDR. But the Affordable Care Act was less the second coming of the New Deal than a recycling of policies first championed by Republicans. The ACA bolstered the private health insurance market through an individual mandate that was modeled on a state-level plan in Massachusetts signed into law by then Governor Mitt Romney. And the ACA's employer mandate drew from the centerpiece of President Nixon's health reform proposal in the early 1970s. The final slide I'm going to share with you is again based on the research of Jacob Bohr of the Commission. This slide tracks life expectancy over time, but at the level of US counties. So the red line here is counties with a high proportion of people voting for Trump in 2016. And the blue line is counties in which Trump received a relatively low share of the vote. Here again, if you go back to 1980, things didn't look too different in terms of life expectancy. Both the Trump voting counties, this is all based on how they voted in 2016, but if you roll back to 1980, the Trump voting counties, and the non-Trump voting counties had similar life expectancy. But over time, life expectancy in these Trump voting counties lagged well behind that in the other counties. Economic dislocation and government austerity, coupled with diversionary racist and nativist political appeals, is not just bad for people's health. It creates incendiary conditions that can threaten the health of our democracy. So which brings me to my final comment, and I'm going to turn it over now to Commissioner Dr. Mary Bassett. This is the other thing about Reagan is that the Trump playbook on racist politics also was rooted in a long history. And this was Ronald Reagan giving a campaign speech in 1980 in Philadelphia, Mississippi, close to where the KKK had murdered and buried 3 civil rights workers in 1964. So let me turn it over to Dr. Bassett to talk more about not just 4 years or 40 years, but 400 years of systemic racism and its toll on health.
Thanks very much, Dr. Grunberg. I'm really delighted to join today as we launch what's a monumental and synthetic review of the current US state of health that bears the imprint, throttling might be a better word, of former President Trump and places his actions in context. I'd like to acknowledge all of the commissioners in this work, and especially Dr. Steffi Wohlhandler and David Himmelstein, who chaired this sprawling and ambitious project, and thanks are due to the Hunter College, their academic home, and to Richard Horton, who models how being an editor takes courage. I've read the entire 40 pages of text of the Commission's report, and I urge everyone who is listening to do so. In order to look forward, we need to look back 4 years, 40 years, 400 years. Understanding the origins of our current distress needs an exponential backward gaze. The COVID-19 pandemic has taught us just what exponential means. The first reported US death was just under a year ago, and now we are hurtling towards 500,000 gone. COVID-19 tracked along the enduring fissures of our society, disproportionately affecting Black, Latinx, and Indigenous people, people who are also disproportionately low income. Overall life expectancy, as you've heard, had already been declining in the United States, and it's now set to decline further. But how long a person lives in the US has always been related to racial ethnic classification. Estimates suggest that white Americans on average have lost less than a year of life. Black people have lost 2 years, widening by 40% the Black-white gap, and Latinos have lost 3 years, greatly reducing their long documented relative advantage. To put this a starker way, in 2020, 65-year-old women died of COVID-19 at the same rate as 53-year-old Latinas, 52-year-old Black women, 48-year-old Indigenous women, and none of these women of color currently would be vaccine eligible based on age, by the way. To anyone paying attention, it was clear that Mr. Trump became less concerned about COVID-19 as its urban impact and racial disparities emerged. This dangerous racist thinking gave this virus, against which no one had immunity, an open highway for transmission. And then in May came the casual murder of George Floyd. The police officer had his hand in his pocket as he snuffed out George Floyd's life. His killing reminds us how brute violence still underlies the US racial hierarchy. Black men have a 2.5-fold higher risk of dying because of a police encounter, and they're less likely than whites to be armed. The call Black Lives Matter captured the nation and spanned the globe, and here is where the 400 years comes in. What happened in 2020 was predictable, right up to the events of January 6, 2021, that led to the impeachment hearings that are now ongoing. In 1619, the first captured Africans arrived in Jamestown, Virginia, and began 246 years of US reliance on enslaved labor. Twin founding facts of the US's ascent as a powerful nation are its economic exploitation of enslaved labor, paired with land appropriated following genocidal campaigns against the people whom the European settlers found here. Stolen lands worked by stolen hands. White supremacy justified both enslavement and the literal destruction of Indigenous people. Just a month ago, the marauders who sought to overturn the result of the 2020 US presidential election carried the symbol of the defeated slaveholding states, the Confederate flag, into the halls of the US Capitol. How then do we move forward? The commission took care to look at the past, and many people who call the United States their home know little of its history. This needs to change, and the report contributes importantly to historical truth-telling. Next, the commission has joined a growing consensus that uprooting racism requires concerted structural action, including compensation to Blacks for nearly 250 years of enslavement, followed by Jim Crow, to American Indians for genocide, land loss, and broken treaties, and to Puerto Ricans whose island was colonized by the United States. Reparations is no longer a fringe idea, and a growing proportion of whites, though still the minority, support the idea. One poll showed an increase from 23% to 39% in just a year of whites in support. Other recommendations to reduce racial ethnic disparities are important, perhaps less novel, but still unachieved. Single-payer national health insurance would not only ensure universal coverage, It would create the basis for ending disrespectful, racially disparate treatment and care. A universally publicly funded system undercuts two-tiered care that has helped maintain a segregated healthcare system, even without single payer. Engaging nation states that have declined Medicaid expansion would be an advance for racial equity. Most are in the South, still home to over half of the African-American population, and similarly correcting the budget of woefully underfunded Indian Health Service should be pursued at once. Action also is needed to address the longstanding and growing underrepresentation of underrepresented minorities, as they're known, in the health professions. Out of 20,000 matriculating medical students, Black men number in the hundreds. Fewer were enrolled in 2014 than in 1978. And a stunningly small proportion of matriculating medical students are American Indian or Alaska Native. The current pandemic reflects how all the ills I've described, white supremacy, a fragmented medical care system, plus chronic and escalating underfunding of public health, and the growing misery of working people, created predictable vulnerabilities that have cost lives and damaged the economy. The most important conclusion of this report is that we not sit on the sidelines. Bad policies have cost many thousands of lives, and those of us committed to people's health cannot accept this. Let's join with others to change what we cannot accept. And now I'm going to turn it over to Dr. David Himmelstein for some final words.
So I'm just very briefly going to touch on the Commission's recommendations, which are legion. We have so many problems that we have an enormous number of things that need to be done. A few of them have already been done, thankfully, by our president, who's reversed some of the executive actions that were harmfully inflicted by President Trump. The COVID response is certainly improving. He's rejoined the WHO and the Paris Climate Agreement and several of the other actions that have been taken in just the few weeks that he's been in office, but many more remain, enforcing civil rights, voting rights, and fair housing laws, and reinvigorating Justice Department oversight of racist policing among them. So we have a variety of recommendations for executive actions and for legislative actions. And again, I won't go through all of these in any detail, and rather I'm going to set a framework. And the framework is peculiarly appropriate for a program coming from Roosevelt House. The Commission spotlighted two waves of progressive legislation, one during the New Deal and the other during the Civil Rights era, that brought America forward and yet left much work undone. So here's President Franklin Roosevelt and Eleanor Roosevelt out front of the Roosevelt House, where this program would be if it were live today. And while Franklin made substantial progress on economic equality, he compromised with Southern Democrats and Southern racists and failed to make progress in many ways on the racial agenda. But I want to quote from his fourth inaugural address. He said, "Necessitous men are not free men. People who are hungry and out of a job are the stuff of which dictatorships are made. We have accepted a second Bill of Rights under which a new basis of security and prosperity can be established for all, regardless of station, race, or creed. Among these rights," he cited, "are those to a useful and remunerative job, to adequate food and clothing and recreation, to a decent home, to adequate medical care, to a good education. If we were returned to the so-called normalcy of the 1920s, then it is certain that even though we shall have conquered our enemies on the battlefields abroad, we shall have yielded to the spirit of fascism here at home." So I think a peculiar parallel in a way to our current situation. But what Roosevelt left undone in the way of anti-racist actions, his wife really in many ways took up after his demise. So this is a picture of Eleanor Roosevelt at a civil rights rally, still the largest civil rights rally ever held in New York City in 1956. And with her was Rosa Parks and Autherine Lucy, the first Black student at the University of Alabama. And here's the gun permit that Eleanor Roosevelt took out after the Ku Klux Klan offered a $25,000 reward for her kidnapping. She was the first lifetime member of the National Council of Negro Women and a staunch advocate for civil rights. But we need to move forward from FDR's second Bill of Rights. And this is in a way what the commission, a summary of the commission's recommendations, to add to those the more modern things that we've come to understand need to be added. Reparations to Black and Indigenous Americans that Mary Bassett has mentioned, enforcement of civil and voting rights, a Green New Deal, which was not thought of in Eleanor or Franklin's era, but has come to be a foremost need in the current era. Criminal justice reform to empty our prisons, immigration reform, a peculiar cruelty of America in many ways, and attention to reproductive rights, which have been sharply restrained under the administration that we've just passed. And as Richard Horton emphasized, global cooperation rather than seeking global dominance. So America needs, the world needs a strong America, but a cooperative America. I'm going to end there and really turn the floor over to Ro Khanna and subsequently to Rebecca Cooney, the North American executive editor of The Lancet. Ro Khanna, whose grandfather was active in Gandhi's independence movement in India, represents California's 17th congressional district in Silicon Valley. He serves as an assistant whip for the Democratic Caucus and is a leader of the Congressional Progressive Caucus. He's one of the few members of Congress who refuses contributions from PACs and lobbyists. Prior to coming to Congress, he taught economics and law, worked as a lawyer, specializing in intellectual property law, and provided pro bono counsel to Hurricane Katrina victims. And he also served as a Deputy Assistant Secretary of Commerce in the Obama administration. Thanks so much for being with us, Congressman Khanna.
Well, thank you to you, David, and Steffi, and for all your work on the economics of single-payer healthcare. I and Senator Sanders, of course, have learned from a lot of your scholarship, and I want to thank Michael Lighty as well for his work on this this issue. I've been listening on my phone to a lot of the presentations and appreciate it. And I appreciate not just the moral case that we need to make for healthcare for all and single payer, the sense that people are chronically underinsured and that this is leading to deaths in this country, not just people who don't have insurance, but also, and this is important, I think, to emphasize, a lot of working class, middle class people who have insurance, but whose insurance doesn't actually help them when they get catastrophic illnesses. So record far too many deaths, far too many medical bankruptcies. But as your panelists and others have been speaking about, it was also an enormous economic burden. We spend all this money, where does it go? Where does 18% or so of our GDP end up going? And I think in Debts of Despair, you had one of the explanations that this is basically rent-seeking behavior from insurance companies, from executives. This is money that isn't going necessarily to productive causes, and it provides extraordinary pressure on wages and jobs. Money that could be going to raise wages for working class families is actually now going instead to pay health insurance premiums. It's putting pressure on companies to outsource or even offshore those jobs because they don't want to hire someone, particularly people on the lower end of the wage spectrum, into their company if it's going to make healthcare premiums. It's not hurting necessarily Tim Cook. And if you're making over millions of dollars as a CEO, fine, the $20,000, $30,000 premium is not a marginal disincentive to be hired. But if you're making $20,000, $30,000, $40,000, and then a company is sitting there saying, now we have to hire them and pay $20,000, $30,000 of premiums, not only is it going to lead to wage stagnation, it leads to those employees either being misclassified as contractors. We see that rampant in my district, or it leads to them being offshored or outsourced. So the current healthcare system we have has led to suffering and death, has led to medical bankruptcy, has led to wage stagnation, and has led to job loss. And those are the four things that I think that those people who care about this need to be making. It is a moral issue. It is an economic issue. And when we get to single payer, we're also going to see a lot of productive jobs created. And why? Because if you're covering everyone, that's going to mean the need for more nurses. We already have a shortage of nurses and more doctors. And you're going to have standards, Medicare standards, that are going to make sure that you have sufficient staffing, particularly in rural and Black and brown communities, to make sure that there are a lot of new jobs that are created, and a lot of the insurance jobs are transferable to other insurance activity. So I'm looking forward to the entire report, and I talked to Michael that we should have a briefing for members of Congress. But I just want to end with this. A lot of people, they think the progressives, we read a lot of theories of Justice John Rawls and moral philosophy, and we do a very good job intuitively of making the moral case. Every person has dignity, should have healthcare. I mean, we understand in this country, if you go make a lot of money, you can have a fancier car and you can have a nicer house, and most people don't begrudge people that. But why in the world should the job you have determine whether you have healthcare? I think it's just counterintuitive to our sense of fairness, that a person's intrinsic dignity, that their job title shouldn't depend on whether they have adequate and decent healthcare. So we are very powerful in making the moral case. What we need to do more, I think, is make the economic case that this is actually going to be good for wages, good for jobs, good for our competitiveness, taking away 18% of our economic spending and lowering it, or at least distributing it in ways that aren't rent seeking. If you talk to the big corporate CEOs, the dirty secret is they'll tell you too much of their payroll is going to healthcare costs, and they would rather have not have the healthcare businesses and be able to do what they want to do if the government were involved. And I'll leave you with this final thought. Amartya Sen, brilliant Nobel laureate economist, he said most countries have a trade-off they have to make between innovation, economic growth, and moral justice, and they are constantly struggling in that balance, certainly developing countries. He said the remarkable thing in the United States is we actually don't have to make that trade-off. We have so much wealth, $1 trillion or more added by billionaires in this pandemic. We have so much wealth and so much possibility of wealth creation that we can do both. We can have continued economic growth, and we can make sure that we have basic justice and investment in education and healthcare. And it's perplexing why we don't have the political will to do something that we have the economic capacity to do. So with that, I'd love to take questions and get your thoughts.
Hi, yes. Thank you so much, Congressman Khanna, for those insightful comments. I am Rebecca Cooney. I'm the North American editor and also the midwife and handling editor of this commission report, as well as the past two US series. And it is really just my absolute pleasure to have all of you here today. And I was hoping that we could start by asking you, Congressman Khanna, as someone who's really working, in the midst of this, and where some of the most constructive changes, potentially around taxation and federal funding for improving health and sort of overcoming these longer term structural issues that as we've noted in the previous presentations, didn't necessarily start with the Trump administration, but have been intensified then. But if, for example, if you feel that there's something that's the lowest hanging fruit, or what do we need to hone in on first?
I appreciate that. I would say there are two places that are low-hanging fruit in terms of getting consensus in the Biden administration. One is the extraordinary racial disparity in healthcare. When you look at Black women and a maternal mortality that both President Biden and Vice President Harris spoke about extensively on the campaign trail. When you look at the distributional inequities with the pandemic of how it's disproportionately hurt Black and brown communities. So I think anything that is focused on closing those racial disparities in our healthcare system is low-hanging fruit in terms of getting momentum across the Democratic political spectrum and support for it. I also think, and I look forward to getting your expert opinions, but when you talk about preschool education and when you look at James Henkman's work about the importance of preschool education, that's also linked very importantly to nutrition and health. And I don't think people emphasize that part enough. They say, okay, let's have universal preschool. But if you look at Henkman's studies, he actually says that one of the key factors of that is having young kids who are adequately nourished and have adequate healthcare screening and vaccinations and all of the rest. And so I think focusing on that is also something that could get broad range support.
Very helpful. I think this touches on very much the next question that I'd like to shift to Kevin Grumbach, and to talk about some of the feasibility that you see as the momentum for single payer system under Biden, and really how do we sort of navigate the discord around the discussion of universal health coverage in terms of getting past that into moving towards an actual UHC plan?
Well, I think there are two things we have to overcome. Three things. One is this issue of cost. I was looking back at the New York Times because Jimmy Carter ran on single payer. People may not remember that, but he actually had to come out for single payer to win the primary in '76. And they asked him, how are you going to pay for it? And Carter said, I'll figure it out when I'm president. And I was thinking, well, I wonder if Elizabeth Warren could have given that answer instead of probably would never have gotten away with that in today's political climate. But I do think that this issue of cost bogs us down. And one of the ideas could be, how do we create a commission to talk about the cost, having general themes of how we're going to pay for this, and convincing people that it's not going to mean huge structural deficits, and it's not going to mean large taxes on the working and middle class from a political perspective. That's one issue. The second issue is, I think this mistaken notion, if you read Bernie and his bill or Pramila's bill, that it would ban private insurance. Actually, what it says is it's similar to Medicare. Medicare, you can get supplemental insurance. Now, Bernie and Pramila have the plans to be so good that people argue, well, they're going to be so expensive that private insurance is not going to be necessary. And my view is that what we should say is it should be a consumer choice, that we are going to make the plans as expansive as possible. But you always have, as a consumer, if you want more, if you want to make sure that you have concierge medicine, you can get that. And if you, by the way, don't trust Congress enough to say that we're going to give you everything that's in Bernie and Pramila's plan, the supplemental insurance is allowed. So there's no banning of supplemental insurance. It's actually just saying that we're going to make it as good and you have the choice. And I think that is very different than saying Medicare if you want it. It says everyone is in Medicare. Everyone, just like every senior is, but supplemental insurance is, gap insurance is there if you actually need it. And I'd love others' thoughts on it, but that's actually what the bill says. And I think there was a misunderstanding of that. The third area of misunderstanding or thing we have to clarify is the jobs question, and making it clear that this is going to create more jobs than it will lose, which is my actual belief, and particularly in rural and Black and brown communities. So those, I think, are the political hurdles. In terms of getting a vote or something, I mean, we're going to push for it. I know I was talking to Michael Eide. One of the ways to push for it is when they come for ACA funding. Pushing for ways to make it clear that we need to move towards a public system. But we don't have the support, candidly, right now in the caucus to actually get it done until we address, in terms of getting single payer fully, until we get some of these questions, until we win over people.
So switching gears slightly, I actually want to pitch this question to Mary Bassett. I think thinking ahead, because we have been so, tired and sort of beaten down by the issue of being immersed in the COVID-19 pandemic, that we haven't necessarily begun thinking about the next pandemics or the pandemics caused by pandemics, especially in Black and Brown communities, sort of emergence of opioid hotspots, et cetera. What do you think we should be looking for avoiding the next public health crises? Oh, I think we need.
You're muted, Mary.
I always forget to unmute myself. I think that we had some slides. I believe that Dr. Wilhelander showed some slides showing the decline in investment in public health. If not, I'll just state that as a fact, that the US has always spent less money on public health than other wealthy nations, and that proportion has been declining as a share of the budget and going down particularly for states and local jurisdictions. So bringing back up the public health funding should be an absolute critical priority. And not only fixing the response, the issues that were outlined, bringing back the group that was sort of dismantled, that is charged with addressing pandemics, but the whole public health infrastructure is too rickety. And it's too rickety because it hasn't had enough funding. I can speak for the New York City Health Department, one of the finest local health departments in the world, I would argue. But you can't do things when you don't have the money to do them. And IT systems are archaic, and that has to be fixed. There needs to be a doubling of the funding of public health. Additionally, there were some good things that have happened as a result of the pandemic with respect to opioids. Methadone is no longer subject to what some people have described as liquid handcuffs. The ability to get methadone if you're using that for medical treatment of opioid dependence. And I don't think we can go back from that. And additionally, we're all hoping to see the Biden administration act on what it said it would do and what it continues to say it will do in making medical assisted treatment much more available, easier for doctors to prescribe it.
And it's such a shame that we don't have more time. There's so many questions that have come in via the Q&A and that also just related to this discussion. But just to kind of end on potentially an optimistic note, to pitch it to David, I wonder if you could tell us that now that the Trump presidency is behind us, what do you think sort of in hindsight is the Trump era going to come to mean for us, and how do we kind of get past this?
Well, I think it's an era of extraordinary cruelty that really caps a longer era of malfeasance from our government. So we've, as Kevin outlined, had 40 years of neglect from our government, but capped by a period of real cruelty. And I think it warns us that we can't go back to those policies before the Trump era. We need to really move forward in a much different direction. And as I tried to point out, in some of the directions that the civil rights era and the New Deal era might point us to, but we need to go beyond them in modern ways. So I think in a hopeful turn, the Trump era has mobilized alternative energies that can move our spirits forward to a very different America. And I think that Congressman Khanna points to some aspects of what needs to be done. I'll say that the Congressional Budget Office recently gave us tremendous ammunition for single payer when they came out with a report that said single payer would actually cover everybody in the United States and decrease healthcare spending. But we need a much broader based change in our social conditions than that. And if we want to avoid a second coming of Donald Trump and the victory of Trumpism in the future, we need to reckon with America's racial history and with the genocide that set our country in motion. So we have a broad agenda that the Trump era tells us we need to address.
I think that's wonderful. There is so much work to be done, and I want to thank everyone immensely who has joined us in the discussion today. Roosevelt House will be making this video available. I know a lot of you are keen to kind of reflect on some of the content that was presented earlier. You can also follow this on social media in The Lancet and go to thelancet.com to read the report. And hashtag Future Health USA is a way to engage with us on social media. And I just want to encourage everyone to be well. Any final thoughts from the commissioners today?
Yes, I mean, I just want to reiterate that a lot of Trump's policies and Trumpism was based on racism. And it's not really an option for people who want to see change to ignore the problems of racism in this country after we saw Confederate flags in the Capitol on January 6th. So we really need to be rethinking how we approach the problems of race to create a society that works for everyone.
And I'll say within the House of Medicine, we have much to do on that, as well as the rest of society.
Thank you. That's wonderful. I think that's all the time that we have today. And thank you again for joining us. And we hope that we will have other events in the future where we can continue to work on these problems together. Thank you so much, Congressman Khanna, for joining us.
Thank you.
Of course, our panelists.